Okay, great. Welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speakers, I have some announcements to make. This CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. As a reminder, evaluations are required for CME credits. You can find the evaluations by following the link in the chat at the end of this presentation, or on our website, or on our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. It's my great honor to introduce our two speakers for today, Dr. Karen Lubomir and Dr. Lauren Okamoto. Dr. Lubomir is an assistant professor in the Department of Geriatric Medicine at JABSOM. She is a geriatrics clinician educator with an interest in health literacy as it impacts health outcomes in culturally diverse elderly populations. She graduated from the University of Connecticut Schools of Dentistry and Medicine and completed her internal medicine residency at the University of California, Davis in Sacramento. Her fellowship training was at JABSOM. She also completed her master's degree in clinical research at JABSOM. She serves as the clerkship director for the required medical student rotation in geriatrics and palliative medicine. Dr. Lauren Okamoto is an assistant professor in the Department of Geriatric Medicine at JABSOM. She's board certified in both geriatric medicine and family medicine. She serves as co-clerkship director of the JABSOM Medical Student Clerkship and director of the resident rotation in geriatrics. She's a recipient of the John A. Hartford Foundation Junior Faculty Career Development Award, and most recently, the Geriatrics Academic Career Award from HRSA. She serves as medical director of several nursing homes on Oahu and is part of the Queen's University Medical Group clinical practice. Her interests include nursing home medicine, geriatrics education, medical directorship, and ethnogeriatrics. Both Dr. Lubomir and Dr. Okamoto are co-investigators in the Geriatrics Workforce Enhancement Program, which is a HRSA grant. Please help me in welcoming Dr. Lubomir and Dr. Okamoto.
Thank you, Dr. Masaki. Excuse me. Welcome, everybody. Dr. Okamoto and I will be tag teaming this presentation, so we'll go back and forth with our slides. Those of you in attendance know the historical significance dating back to the 1700s of successful immunization against smallpox, of protecting individuals and communities through immunization programs. Vaccines continue to be one of the most impactful interventions that save millions of lives worldwide every year. Besides the obvious health benefits, there are also economic benefits. They drive down healthcare costs, they increase workforce productivity, and they mitigate the disease burden on societies. Given globalization and climate change, we're likely going to experience more infectious emergencies, with immunizations being one of the largest defenses that we have to combat the spread of disease. That's where you all come in as promoters, or another term for ambassadors of vaccination programs, because healthcare professionals actually are the most trusted sources of information. We thank you for joining us today. Our objectives, I want to thank the CDC and American Geriatric Society for providing some of the slides for this. Our objectives are to review the strategies to actively promote the National Vaccine Advisory Committee, NVAC, which is a division of the Department of Health and Human Services, that they've come up with standards of adult immunization practices. The other thing that we'd like to have you learn is to improve vaccination rates among older adults by offering the latest vaccine recommendations from the CDC and gaining insights on combating vaccine fatigue, or otherwise known as hesitancy.
So first of all, thanks, Karen. We want to present some background data for you to digest before we get into the rest of the presentation. And here we have our first slide to demonstrate some actually rather concerning data regarding older adult immunization uptake in the US. So despite the CDC recommendations for adult immunizations, A survey done in 2022 showed only that 26% of our older adults in the US have received all recommended vaccines, with the influenza vaccine demonstrating the greatest uptake at 70% coverage, and the zoster vaccine having the lowest uptake of around 44%. So this is actually surprising. I was surprised myself. And looking at the COVID vaccine, the these are the numbers. The uptake has been dwindling over time, as we know, with 95% of older adults receiving the first dose of the vaccine initially, but that number kind of dropping to 37.5% for the 2023-24 booster. So we see kind of a downward trend here. Okay, Karen?
Yes. Just keeping on that, some of the data that's interesting is that for the rate of hospitalizations, this is CDC data, they looked at the 2022-23 flu season. And as you can see, the older adults are disproportionately affected by influenza and increase the number of hospitalizations rate and also increase in severity of the disease. Next slide. If one thing about hospitalizations, if they are hospitalized, they usually have longer hospital stays and they're less likely to return home independently. There will be more nursing home admissions or admissions into assisted living. This year, the flu actually hospitalizations just from October 1 to December 7th for this 24-25 year, we've already had 33,000 hospitalizations. For COVID, it's been 120,000 hospitalizations, and for RSV, about 45,000 hospitalizations. Going on and looking at mortality rate in older adults back in the 22-23 flu season, you can see that they are also disproportionately affected by influenza. And the rate is about 27 out of 100,000 deaths. This year, the estimated death for the 24-25, just October 1 through December 7th. I mean, maybe we're just into the, well into the season. Flu deaths have estimated about 3,000, COVID about 13,000, and RSV about 2,300.
Okay, so why are we concerned here? We know that older adults have a higher risk for morbidity and mortality, as Karen demonstrated in her slides, due to preventable infectious disease. Yet, vaccination rates are not improving and in some cases decreasing. So, as healthcare providers, we have an opportunity to join hands in improving vaccination rates for older adults as an age-friendly intervention. So this figure is from the National Health Interview Survey, which shows that we have not been able to improve vaccination rates over time. So they're looking at the years 2017 to 2022. And if you look at all the different vaccinations, we've stayed relatively flat over the last 5 years, with the only exception being the zoster vaccine, which unfortunately is really the lowest uptake. So we had a lot of improvement to make, but we haven't made the improvements that we expect given the education and campaign across the United States to get these vaccines. Karen?
So the CDC, as I said before, has adopted the standards and called Standards for Adult Immunization Practice. And these are 4 steps really for standard of care for all immunizations. And they're really practical, they're proactive and measurable. So let's look at these 4 in more detail. So there's assessment, recommending vaccines, administering or referring for vaccines, and then documentation, whether the vaccines were received. In more depth, this is the next slide. So here's some tips. Looking at the assessment step, it's an opportunity to evaluate how your practice is doing, kind of a QI, if you would, improvement project. Pulling a sample of patient charts, analyzing, making analysis through the electronic health record data, to see whether or not your patients are receiving the recommended vaccinations. Also for yourself, staying informed of the CDC recommendations for the various age groups. There'll be a link later in this talk to those. Also, we're using reminders within the electronic health record to assess how and when your patients may need to be vaccinated. The second step is, or practical step is recommendations. So these, I think of sort of the 4Ms, taking what matters most, the M of what matters most, and making very specific recommendations to patients, addressing their individual concerns so that you can align your recommendation with what they've identified as what matters most. This is using very clear and specific language. For example, it looks like you're due for your flu and COVID vaccines and you haven't had RSV before. Because you are over 75 years old, you're more likely to get sick and maybe even be hospitalized if you get one of these illnesses. Vaccines can actually cut your risk of serious illness or hospitalization by half or more. Very specific information that you'd be giving. Can build on your trusted relationship. I recommend very powerful statement. And don't forget to ask follow-up questions. Do you have any questions or concerns that I can help answer about vaccines? So that would be the second step. As far as administration and referrals, offer the vaccines at same visit. Research shows that people are much more likely, if you're prepared, to give the vaccine at the visit. Unfortunately, we don't store all the vaccines at offices or various sites. So if you are going to make a referral, make sure that they have that information with which they can act upon easily, where to go, how that would work for them. And then the last is documentation. The recommendation is to participate in your state's immunization registry. Help your office, your patients, and other patients' providers know which vaccines your patients had. I can tell a side story about patients not remembering that they were already vaccinated, getting a second vaccine, but we want to avoid that by good documentation. Also, lastly, is following up to confirm the vaccines were referred. Hawaii does have an immunization registry. And there's two, this is how we know what the patient received. If this is utilized, there's two methods to submit. First, there's a data exchange where you can upload current or a backlog of your patient immunization records. The second is a web-based exchange, based interface that's kind of real-time data entry. This does require training, and the website, which is identified in this slide, is a place for more details.
Okay, so here is some data from our own state, interesting, showing influenza vaccination rates in our older adults. And the good news is that our rates have been increasing since 2018, so we see that upward trend. This slide shows influenza vaccination rates among different ethnic groups in Hawaii for those 65 plus and above. Although there is no significant or statistically significant differences from the overall rate, there are some interesting trends, as we can see. If you look at American Indian, Alaska Natives, Native Hawaiians, and whites had lower vaccination rates compared to the other ethnic groups. Here's another slide examining rates by sex. So females, females had a higher vaccination rate than males in the state. Now, if we examine employment status, those that were retired and unable to work, I found this interesting. Those that were retired and unable to work had a higher rate of vaccination compared to those that were employed or were a student. And I don't know, they combine homemaker with that, but it seems that if you were employed or busy or doing something, you were less likely to get vaccinated by influenza as an older adult in the state of Hawaii. So looking at some socioeconomic factors like poverty level, we see that those who made from 0 to 130% of the federal poverty level had the lowest rate of vaccination. So making those who made less were less likely to have received the vaccine. And this was statistically significant when compared to the overall rate. This slide actually shows some trends in vaccination by education level, with those who did not have a high school diploma having the lowest rate of vaccination. So more educated with a bachelor degree or higher was showing the highest rate of vaccination in the state. Okay. All right, Karen.
So, what are some of the strategies to promote this standardized practice? Two questions to ask, and or what initiatives in your own practice or your health system that you're affiliated with do they have to promote vaccines within your own patient population, and also getting the word out among healthcare professionals? And then who are the champions that assist or will be able to assist to improve vaccination rates in your practice or the health system that you work? Next slide. So some examples I found of health systems here in Hawaii, where we had vaccine promotions. Kaiser had opened an immunity with sweepstakes. Department of Veterans Affairs had a flu and COVID one visit, two vaccines promotion. Queens Health System had walk-in Wednesdays and Fridays, and HBH had a vac squad bus that actually went out to school campuses. You may all know of other promotions within your health systems. Next slide. And we also have champions in our state of vaccinations. This year's champion is Dr. Sandra Chang. She's in the Department of Tropical Medicine, Medical Microbiology, and Pharmacology. And she was named by the Association of Immunization Managers, AIM, as their immunization champion. The next gentleman there is Gerald Oda. He made a YouTube video. He was a champion Little League manager and promoted vaccine uptake. We have also Dr. Lee Bueconsejo Lam, who's our Associate Dean for Academic Affairs, and CDC named her the 2022 Immunization Champion. And I think you'll recognize Dr. Governor, not sure which is it. Josh Green. That's him in 2019 in Samoa. During the measles outbreak, there was a lot of vaccine hesitancy at that time, and he was one of the leaders in that effort. Excellent.
Hey, thanks, Karen. So, given the disparities noted in vaccine uptake by race, income, education level, it is also important to vaccinate older adults at every point of contact within the healthcare system. So this slide is illustrating that, which we always find opportunities to vaccinate when we're thinking about our healthcare system, even if it's just a short-term post-hospital stay, even if it's a respite nursing home stay at any point. If we have the opportunity, we should find the will to vaccinate. Public health officials even discuss whether or not actual medical settings are even the best places to disseminate vaccines. So there's talk about, are there places in the community that provide better access for our patients? So utilizing Meals on Wheels or home health services, churches with a pastor involvement, barbershops. I think they did a study in that certain barbershops were more effective in disseminating vaccines than actual healthcare institutions in certain communities. So it's interesting. And we should not forget our caregivers in the community. Healthy caregivers are vital to keep our patients healthy. We often do a good job at this in institutional settings like nursing homes and hospitals where we vaccinate the staff and caregivers. But within the community, I think there's a lot more work to be done. I think pediatrics does a good job in the community, sometimes offering the caregiver vaccination at the same time that the pediatric vaccines are being offered within a pediatric office. So there's a lot more room for us to strategize how we can effectively vaccinate our caretakers. Oh, we just wanted to kind of go over I'll go through this chart. This is a behemoth vaccine chart. It's become more and more complicated with the addition of more vaccines, even since I graduated medical school. Some vaccines recommended for older adults include COVID-19, influenza, RSV now, Tdap, pneumococcal, zoster. So as you can see, these schedules have become very complicated with a lot of updates, an enormous amount of vaccines that healthcare providers often have difficulty tracking it, let alone the patients knowing which and what vaccines they received or what they're due for next and the time periods in between the first and second dose. We often see vaccine fatigue in patients and honestly, even in healthcare providers, because there's so much going on, especially post-COVID pandemic. All right. Well, Karen?
Okay, yes. So vaccine hesitancy, it's been defined by the World Health Organization as refusal or delay in acceptance of vaccines. Other terms you might hear are vaccine ready, like those, vaccine hesitant, or vaccine resistant, otherwise known as anti-vax. But to know that anti-vax and vaccine hesitancy are different challenges. We know that we'll be concentrating more during this talk on vaccine hesitancy. The reasons for vaccine hesitancy are quite varied, multifactorial. There's been actually a lot of studies looking at this issue. We also found that increasing vaccine uptake requires education, really clear communication, and the community needs to be involved. Next slide. So why are people hesitant to get vaccinated? Well, it's been an issue for a long time, although especially among can you go back one slide? Oops. Sorry. It's been an issue for a long time, especially like among pediatric population, right? I talked about Samoa, that measles outbreak was related to vaccine hesitancy. And it really became more apparent actually with COVID epidemic because there's increased skepticism that was fueled by misinformation and amplified on social media. Next slide. So as I said, this vaccine hesitancy has been well studied. And these studies really look and have determined sort of three subtypes of hesitancy to consider. The first one is refusal. Outright refusal. It can vary though in strength, like just I don't want it today, or it may be around one specific vaccine, or I'll consider refusal at one point in time, but not at another. So not to give up, offer at a later date would be the recommendation there. It could be related to deliberation. This is somebody who wants more specific information. They want to know more about the side effects. They have a wait and see maybe attitude to see the magnitude of the illness or their own threat of illness. They really need more reassurance with this type of hesitancy and information. The last is disinterest. And it's kind of people have a very, they don't really think they're at risk for getting the disease. And in general, people aren't that good at judging their own personal risk in certain situations. They actually usually consider their risk as much lower than the average person. Lauren.
Okay, so in thinking about or strategizing ways to increase our patients' willingness to receive vaccines, we have to understand some of the ways we think as humans. We have these biases, and our biases are very well established and very difficult to change. Some of the biases that may sway a person to accept or be hesitant to vaccination are things like availability bias. So in general, we tend to notice and believe things that are easily available, whether it's like on a social media platform, a TV commercial, and the YouTube videos that kids are watching that's inserted into that. And thinking about how we can harness this information and in a sense turn this to a bias toward receiving vaccines. So we should think about that. There's confirmation bias. So in general, as people, we tend to look and pay attention to evidence that confirms our personal beliefs while ignoring other evidence that's contrary to it. So we have that bias. So we only hear certain things. Okay. So what groups of people are more likely to demonstrate hesitancy? And again, it's I think you can guess based on some of the data we presented earlier from Hawaii, but those with lower education level who are younger actually face barriers like transportation barriers. Certain ethnic groups or races, those identifying as Latino, Hispanic, Black, or Native American ethnic groups are more likely to be hesitant to receive vaccines. So what are the reasons? And I think Karen has touched on some of this in her dialogue earlier. It's regarding safety concerns or many reasons, historical institutional trust. And in some studies actually noted that it's the most recent episodes of your institutional experiences that have an impact on this trust, whereas in the past we thought about like really historical things like some of the older clinical trials that we know of. But they said actually more recent experiences are those that are embedded within patients' minds. And then there's this whole disinformation versus misinformation. So misinformation is false or inaccurate information. So just plain getting the facts wrong about vaccinations. Whereas disinformation is false information deliberately intended to mislead. So we have to combat that. And then there's the complicated cultural beliefs that vary between groups of people and individuals to think about when strategizing how to increase vaccine uptake. So this is a good example. It's a local example here. Trust in a scientific community is the best predictor of receiving vaccine across groups. So in Native Hawaiians and Pacific Islanders, trust had a major influence in vaccine hesitancy. So there was a study working in collaboration with the Pacific Alliance Against COVID-19. They surveyed 1,121 Hawaii residents during the group's COVID-19 testing events. And of the respondents, this is a lot, 61.7% identified as Native Hawaiian and Pacific Islander. They observed that trust in an unofficial source explained vaccine hesitancy. So it's kind of trying to get the patients to trust a specific official source. But if they did not, then they were very hesitant to get vaccines. So that was sort of the root cause. Okay. Karen?
Unmute myself. So what is helpful in reducing vaccine hesitancy? It's quite a well-researched area, both at the individual level and community level. I found a lot of literature outside of the AGS. Australia had a lot of papers on this, but also just looking at the CDC and other resources. Next slide. So the definition of a successful intervention, okay, they targeted two outcomes. First was, did the intervention improve vaccine uptake? And they considered success if there was an increase of greater than 25% uptake by that intervention. And the second target or outcome they looked at was knowledge and attitudes. And they considered the intervention was successful if there was an improvement of greater than 20% in the knowledge about that specific vaccine. Next slide. So successful interventions kind of are, they're kind of three very broad categories. Their interventions included healthcare provider training. This is health professional training at all levels within the health system. And that was to facilitate better communication, improved information exchange, and really embellishing the face-to-face communication for all members of the health system with patients. The second was embedding knowledge into the hospital or clinics or procedures or standard operating procedures. This is more of a systems level. So somebody being admitted to the hospital or at time of discharge, having any information, the vaccines available, giving information about that, clinic procedures or something, so admission even for outpatient surgery or hemodialysis patients, the procedures or information there. It also kind of extends over into mandates at certain systems for training and vaccines, increased the successful uptake of vaccines or knowledge about vaccines. The third way was improved convenience or access to vaccination, as Lauren already spoke about. And this is things like you've all seen, right? Safeway offers vaccines along your centers, lobby of your workplace, schools, all those kinds of things, but improving convenience. You walk right by and you get poked. Lastly, which is not on successful, which is not on this slide, are a few other things. Information campaigns for ethnic groups or persons with specific health conditions, such as dialysis patients, pregnant women. Also, targets to unvaccinated populations. The last successful intervention was, I think I alluded to before, was community-based actions. This is with local leaders supporting vaccination programs or supporting vaccination events, and that would be, say, at a religious organization. Next slide. What things that aren't found to work? And this was defined as had a less than 10% increase in vaccination uptake, because it didn't really improve or had some mixed effects on improving hesitancy. The first one was mass media campaigns, right? Those letters, those infomercials or whatever did not seem to benefit or increase uptake. The second, here's where the mixed increase in effect on hesitancy, brochures or pamphlets. And we know sort of from a health literacy that if you write down all the words, it might look scary. There's nobody to sit there and interpret it for you. And you might just pick out the words you recognize and might be off-putting. So brochures and pamphlets not found to be successful. And the last were incentives. Although you see them all the time. It'd be food or goods that you would receive upon receiving your vaccination. Longs, 20%, $5 off, whatever, or Safeway, 10% off your bill, well, all those kinds of things that we know about. But incentives overall have not been as successful as the other aforementioned categories. Next.
Okay, so now we're going to move into some practical strategies to address this hesitancy in a clinical setting. So an NSF study looking at different sources and the degree of influence on hesitancy compared official scientific reports, patriotism, harm reduction information, social norms, and personal physicians as areas of impact. And what they found was that the most impactful was if a patient's personal physician recommended vaccination. I found that. I mean, that's actually it's great for us, right? So so as physicians and healthcare providers, it seems that we are the ones who will have the greatest impact and influence. Our job is to be a trusted source of information and trust. We know that has a big influence in how people accept vaccination. It takes time to do this root cause analysis, as to find out why our patients are refusing or have hesitancy, because it'll be an individualized approach with each patient having a different reason or root cause as to why they're hesitant or refusing. It may take many visits. It's not going to happen in the first visit, but over time, it might even require an interprofessional approach. So in some of my nursing home patients, it's not just the doctor, but other team members who have good relationships with the patients and who they trust, such as a social worker or an activities aide, that might be able to convince the patient, and involvement of family members that they trust as well. You will not be 100% successful, but every additional consent and vaccination counts, so don't give up. It's really not one size fits all, as we know. We have to address individualized needs, like some of the health literacy needs, English language barrier or cultural barriers through the use of interpreters, and maybe dissemination of information in other languages. The utilization of cultural brokers has been helpful. Engagement of community leaders and also religious leaders that individuals trust. So, okay, Karen?
Okay, I just want to do a little bit deeper look at the misinformation and disinformation and some practical tips for that. I just want to define the two terms. I know Lauren touched on it, but this for misinformation, it's false information that may or may not be misleading or intentionally misleading. Like a friend tells us, don't get the vaccine. I heard you can get sicker from the vaccine than from the actual virus. Your friend really has your best interests in mind, but there's misinformation. Or information, other way, form of misinformation may come like information that ties things together that aren't necessarily true. Like my sister got the vaccine and then she died the next day. That's a correlation, not causation. So how do we combat that, or how do we address that? You need to focus on the facts and don't restate the misinformation. Regarding disinformation, it's kind of more nefarious with false information that's given purposely to mislead people for gain. Examples of this be the leveraging of COVID vaccine information for political gain or political or notoriety. Vaccines were developed too fast; they're not safe. Or vaccines attached to my DNA and it's going to change my genetics. Or no need to get the vaccine. COVID's no worse than the flu. So ways or practical ways to deal with that directly state that's not true. Or regarding the change in your DNA, you might say, you're concerned about the vaccine impacting your DNA. Actually, the vaccine is made from mRNA, not DNA technology. That's a piece of genetic code that goes in and tells your body how to make antibodies against the virus. Then that code is destroyed after helping your body make antibodies. The vaccine doesn't alter your DNA at all. That would be a very clear factual way to combat that. Supporting, I just want you to remember that supporting vaccine hesitancy, it's a process. I kind of think of it a little bit like advanced care preferences and code status discussions that we have. It may take multiple conversations and very clear communication to address what your patient's concerns or their family's concerns are. So this last couple slides, we have some resources for you. The QR code that you see here, they're free from AGS. You do not need to be a member. The QR code will take you to a vaccines.agscocare.org site. If you register, if you want your CME, but you don't have to be an American Geriatric Society member. One note on this lineup of items is that the Essential Vaccines mobile app is actually embedded within the last app, the AGS iGeriatrics app, which is very useful for many things. We have our medical students download that app, but it's embedded under that app. I didn't find it independently. And then the last slide is these are the free online educational curriculum. There are CME credit for AGS members. Sorry. Anyway, I take that back about free credits for non-members, but the modules are free for non-members. They do cover these 5 items, including things like coding. They go to much more depth into some of the issues that we've already highlighted and through podcasts. They have slides, they have transcripts, and as I said, available to you by going through the QR code there. I just want to thank you for becoming vaccine ambassadors, and I'm not sure if Lauren has something else to add.
No, thanks everybody for attending our grand rounds. Um, we're now done with our presentation. So if you have any questions, you can just unmute and ask them. I haven't read the chat or anything.
Thank you, Lauren and Karen, for a wonderful presentation, extremely informative. Yes, our audience, please go ahead and unmute yourself and ask. We have a small enough group that we can do that. I just had a comment. You mentioned that for vaccines, the best way to convince people is physician advice. And actually, that's true for so many things, including smoking cessation. People think that the most effective way is, by giving meds or patches or whatever. And actually, physician advice is more valuable than any of those things. So we have a lot of influence over our patients, and we should definitely try to use it wisely.
Yeah,
Any
I was not pleasantly surprised because I thought, no way, physician advice. But they really did do a recent study on it and it came out as that was the most influential.
Any other questions or thoughts?
Hi, thank you for your talk. It was really good. In the nursing home, it's a whole different situation because you probably have staff from the nursing home getting consents and trying to, go down the line and vaccinate as many patients as possible. So I do ask them to give me the list of names of those who say no. So at least I can follow up. And so that the nursing home doesn't take it at face value that, oh, the daughter of this patient with dementia said no, or the patient said no. So I do request from the nursing home, please tell me the ones who have concerns or refusals of vaccines, so at least I can be notified to call the family and discuss with them very patient-specific recommendations, like you said. So it's more meaningful as opposed to a stranger from the nursing home or, maybe one of the infection prevention nurses calling saying, we're vaccinating everybody. Can we give this to your mom? It's a little bit more personalized to reinforce that message for the nursing home. It helps a lot.
Yeah, thanks,
It's
Cody.
a really
That's
good point. Yeah.
Do you get a good uptake then, Cody? Does it change? Like what percentage? Can you guesstimate?
I would say maybe for the COVID vaccine, especially in the past, since the pandemic, I can get at least 50% to come around because after a while, the families become familiar with how miserable it is when there is an outbreak in the facility. And I tell them it's not just for the patient in the nursing home, but also for everyone because you remember what it's like, and we're doing our best to prevent those outbreaks. But because we know it's difficult to provide really good care and just quality of life and activities and safe visitation for everybody in the facility. And so it's, patient specific and also my plea to them easy enough, then they also, are a little bit more understanding about living in a congregate setting, what that means you're part of a community as well. And so some, maybe about 50% of those families, they really do, appreciate the care that they receive in those congregate settings. So that helps too.
now with the recent trends I noticed, is that our patients are pretty good at getting vaccines in the nursing home. So they have now it's required to report COVID pneumococcal vaccines, I think. Whereas the staff is actually the biggest barrier right now to getting vaccines, and we see really low rates of staff uptake. And That's another bad. I don't know if anyone has ideas on how to do that, but
Yeah, I
So
think
I think
also,
that's chronically been the issue is having really low staff rates and actually immunization of the patients, although but they don't mount a great immune response anyway. So really immunization of the staff is more effective in preventing these outbreaks. And that's a big struggle for many of the nursing homes.
I think in outpatient practice as well, when you're working with a family, you have the younger one saying, "Oh, I'm not getting vaccinated," and you think, "Oh, think of Tutu, right? She's older. You get sick and you give it to her, she'll get very, very sick, even though she's been immunized." I mean, it's not 100% for her protection, so you need to protect all those around her. So I would also say in the outpatient setting, it's an effective strategy to combat hesitancy or address hesitancy.
Last year, I know one of the big issues in the nursing home, the COVID especially, was really delayed in being administered in all the nursing homes. And it was partly because for many years, the government had made COVID vaccinations free of charge for anybody. And then that changed, when they officially declared the pandemic over or whatever that was. And then suddenly, the nursing homes were scrambling to find out who's covered and how are they covered and all of that. And that caused a huge delay. And I thought that was so ridiculous. But that's kind of what happened. It seems to me like it makes sense to make all vaccinations free for everybody because it just saves the system so much money. But, it didn't happen. So, any other thoughts or
true.
comments from anyone? Yeah.
Yeah, thanks.
If no more comments, then John or Justin or somebody, if you could put the link for the evaluations in the, oh, it's on already. Thank you, John. So if anybody who wants CME, you need to do the evaluation form. And if not, I'll again thank our two speakers, Dr. Okamoto and Dr. Lubimir, for a wonderful presentation and a very good discussion as well. Okay, thanks everyone. Thanks for attending.
Thank you.
Thank you.
Bye.